Thank you very much. I stand between you and home. So I am going to talk about treating, testing, targeting triple-negative breast cancer. And what you will find from my presentation is when you hang around somebody too much, you start thinking alike. So a lot of my slides are going to resemble Lee's. I hope I give a different flavor to it. So let's go. We like to debate. All right, conflict of interest, objectives for the study. So first, I've discussed this. Anybody who's heard me talk have discussed this trial before because I think it's a very important trial. It's one of the first trials that was presented by Fabrice André and the French group, I think San Antonio 2 years ago, looking at a targeted approach compared to chemotherapy. And in that trial, they selected HER2-negative breast cancer patients who were receiving a response to chemotherapy. They've received 6 to 8 chemotherapy trials. They've had molecular profile, somatic, and some germline. And those who were having some form of benefit, PR, CR, stable disease, were then randomized to receive a targeted therapy based on their profile versus chemotherapy to see which one was better. And it turns out in that population, if you took the targeted therapy approach, those patients overall did better, suggesting that really we need to start thinking about a targeted approach for metastatic patients. So clinical relevant biomarkers in triple negative. Lee started this talk. ER, PR, HER2 is the foundation of what we do in breast cancer. If you're not doing this well and you're treating breast cancer patients, then we're starting on the wrong end. So great pathology, having good controls is absolutely important. We know this is IHC method of determining expression. Based on those ER-PR, the early breast cancer trialistic group showed in their 2010 meta-analysis that given patients who are ER positive, tamoxifen showed a benefit, the ER negative really didn't, and that sort of helps and separates how we treat. Similarly for trastuzumab, shown by the Slayman Group, 2005 New England Journal, addition of trastuzumab to a HER2 positive group showed that there is benefit in not only progression-free, but overall survival, whereas Cucini, and I had to Google how to pronounce his name, and I think it went Cucini. That's what Google told me, showed that in the HER2 low space, giving trastuzumab to chemotherapy made no difference. And so those patients received trastuzumab. A few other trials, again, looked at the ER negative, that they respond better to chemotherapy. And this is just showing a path CR versus ER positive. But what is our standard? What do we call ER negative? And this is based on some analysis of overall data. And what I'll show you here on this, I know this has a pointer somewhere. Do you know how it is, Lee?
It's a separate device.
Oh, it's a separate device. Separate device, thank you. So essentially what this is, and if you look at the table on the right over here, it just shows the proportion. If you multiply those numbers by 100, it will tell you what we generally get in pathology. So 0.01 would represent a 1% expression, and the H staining is 1. What you see here is the higher the percentage of estrogen, the higher the disease-free survival, whereas the 1 and 2, which is about here, less than 1%, and even the 2% over here, 1 to 10%, didn't really benefit as much. So our standard really now is ER less than 1%, but when you look, the 1 to 10% really sort of groups together with the less than 1% over here, suggesting they may not even get as much benefit. ASCO CAP guideline, finally in 2020, separated, and Lee talked about that, asking us and the pathologists to really separate the group for 1 to 10%. And if you read what it says, and I'll start on the second sentence, there is really limited data on the overall benefit of endocrine therapy for patients with ER low, that is 1 to 10%, ER expression, ER low levels of expression, sorry, but they currently suggest some possible benefit, so patients are eligible for endocrine therapy. However, there is data to suggest that cancers with these results are heterogeneous, both in behavior and biology, and often have the expression profile similar to that of an ER negative. And we all know if we treat those patients really behave more like triple negative than they do ER positive. Again, triple negative, I always say it's a diagnosis of exclusion. We put it all in the bracket if it's not ER positive, PR positive, or HER2 negative. Lehman, in his 2011 publication, was first to sort of say by gene expression profile that they're probably about 7. It's probably been cut down a little bit to be about 4 or 5 different subtypes, but triple negative are not all the same. We just haven't separated them out yet clinically for treatment, but we treat them all as one, but they're not all the same. So the HER2 low space, you've heard this, and I'm not going to go too much in that. Again, it's 45 to 55%, and it's that IHC 1+ is considered low, or the 2+, which is FISH negative. I will add to the conversation. We saw DB04 from Lee and Heather, and Lee talks about TDXD and the mechanism of action with the bystander effect, which is very important. And I will hop on here in that, and Heather just mentioned that, in that particular trial, it was mostly a hormone receptor positive population, but there were about 60 patients who had hormone receptor negative, HER2 low, and they were able to randomize 58 of them. 48, that's 58 of them, but it showed that there was benefit not only to the hormone receptor positive, but the hormone receptor negative, HER2 low population for the addition of TDXD versus treatment of physician's choice. So in summary, all breast cancers should have IHC testing, and it should be done with appropriate controls. That's been established. One should strongly consider treating ER positive low patients as triple negative, as the biology is most often consistent with triple negative. In your functioning of clinic, I think it's imperative that all patients, metastatic breast cancer patients, at least you recognize whether or not they're HER2 low or not, and you should put it in your note or somewhere you can easily find it when that time comes in, because that drug is so very important for that patient population. Pathologists too. When you are reporting your HER2 status, don't just say HER2 negative. Give those values because they are important. And I also think that if you have a patient who needs a response, or who's HER2 low, HER2 0, or progressing, and there's a relatively easy accessible lesion, consider rebiopsying to see if that patient, because that can change. TROP. So again, TROP is a target, and Lee talked about it. I'm not going to talk much more about it, except to point you to that human diagram on the right, just telling us that in malignant tissue, and Lee talked about lung and breast, that TROP is expressed on the malignant cells, but not only lung and breast. You can see the other tumor types here and the expression of TROP on the surface of those malignant cells. So those can be targets. TROP is not something that we test to determine treatment, and that's based on the ASCENT trial that Lee talks about. I am not going to go much into it except to say this sacituzumab govitecan was very effective. In fact, this trial was closed early because the sacituzumab was outperforming standard of care so much that they felt it was unethical to continue the trial. There was overall survival and progression-free survival benefit in that group. But does TROP expression correlate with response to the drug? And the answer is yes, although everyone, and you can see, so in this, the authors separated high group, medium, and low expression of TROP, and looked at whether or not there was clinical benefit based on expression. And the answer is yes. So in the high group, you have higher overall response, you have higher disease-free survival, progression-free survival, and overall survival based versus TROP low expression. So you get a better response if you have higher TROP, but importantly, even if you had low TROP, you did better than standard of care by using sacituzumab. So we don't have to test for TROP for those patients, but do know that the higher TROP expressing tumors probably have a deeper response. So in summary, sacituzumab is indicated for second-line or beyond triple-negative breast cancer. TROP status, as I just said, is not a requirement for making a decision for sacituzumab, but keep in mind the expression does correlate with response. Sacituzumab is considered, should be considered, I've had this question before TDXD for a metastatic breast cancer patient. And the reason is because of the studies. In DB04, it was exciting, but as you saw, there was only 60 patients who were triple negative, and it was a subgroup of the entire population. The ACCENT trial, that was the primary outcome. It was a study dedicated at looking at that population, 529 patients, and there was progression-free and overall survival, and that should go before TDXD in a triple negative population. PARP inhibitors, that was talked about earlier. Again, just for, I know there's some medical students and residents in here, how do they work? The cell, the DNA of those cells get damaged all the time, and the body has foolproof method of repairing it. Importantly, it has to be repaired correctly. If not repaired correctly, then we can start developing malignancies. So in the top box over here, a normal cell, so we're going to talk about really two repair pathways here, base excision repair and homologous recombinant repair. Base excision repair is a highly error-causing repair. Its only thing it's concerned about is just fixing and repairing single branch break. If there's a break, it repairs it. If there's a break, it repairs it, and not as concerned about what you're putting in there. So there is more likely to be errors. Homologous recombinant repair is more error-proof repair. So that's a very good way of making sure that the cell gets repaired and repaired correctly, but it's only really for BRCA, it's only really important for double-stranded break. So in the box down here, if you were to inhibit PARP and that cell consistently getting single-strand break, eventually it's going to have a double-strand break, and BRCA can come in and repair it appropriately. Top box over here, if BRCA is not present based on mutation, then PARP is what is being used primarily to repair those DNA. That DNA may have a lot of errors in it eventually because it's not really concerned about doing, so it's an error-prone repair, but that DNA will be repaired, the cell will survive. So the technique is in BRCA-positive tumors who lack the homologous recombinant, if we were to also inhibit the PARP, that DNA will never really get repaired, and then the cell will just commit suicide, apoptosis, and die. And that's the whole idea behind it. It took a little bit more time up with this because Heather went over this. This is Olympia, looking at a specific population of patients who have BRCA mutations, both triple negative and ER positive. Most of this population was triple negative. And you see the criteria here. I want to harp on that a little bit. In the neoadjuvant group, triple negative who got neoadjuvant chemotherapy didn't get a pass CR. They were candidates for this trial. In hormone receptor positive, you had to not have a pass CR, but also meet a high-risk group, which is CPS-EG. And in the adjuvant group, PT2 or N1, or hormone receptor positive with greater than 4 nodes, they receive olaparib versus not. I have looked, and I look everywhere, and it's the hardest thing to find what exactly is the CPS-EG, and this is a table showing it. Essentially, you get a point for having, or point or two for having each one of these, meeting one of these criteria. And then you add this up, and those patients, if you're 3 or greater in the hormone receptor positive, you meet criteria for it. As we've seen, there's PFS and overall survival benefit for the addition of olaparib in the adjuvant setting for those patients. The Olympiad, and Heather just mentioned that again, a lot of the studies enrolled both ER negative and ER positive. The Olympiad study had about 50-50, whereas Embraca study had about 45 to 55%, 45 being ER PR negative, but that showed progression-free survival, but not overall survival in the ITT. I will talk about this important study, which was a small phase 2 performed and presented by Dr. Tong, looking at metastatic patients who've had germline or somatic, meaning tumor mutation in synthetic lethal genes, and those patients were treated with olaparib. In short, what it showed was that in patients with germline, metastatic that is, if you had PALB2 mutation and you got olaparib, there was a response rate of almost 80%. Those patients respond even if the mutation, germline in PALB2, not many patients had BRCA in here, but we also know that from Embraca and Olympiad that those patients benefited. Importantly, in somatic mutations, that there was also benefit. Again, the type of patients that were recruited, but you see if you had a BRCA mutation, there were also very good response rate to somatic mutations with the use of PARP inhibitors. So to summarize, triple-negative breast cancers, who should get germline testing in the early setting? And again, the requirements or the guidelines are slightly different. The American Society of Breast Cancer Surgeons think everybody should get tested. ASCO and NCCN are a little bit more predictive, but essentially in summary, triple-negative, where there's treatment indication, less than 50 male, strong family history. In the later line, that is in the metastatic setting, because there is a treatment option, really those patients should get germline or somatic testing. Even if those patients don't have a germline mutation on somatic, it doesn't mean that they don't necessarily have a germline mutation. Let me state that again. Even if they don't have a somatic mutation in a high-risk gene, it doesn't mean that they don't have germline. It misses about 10%, so keep that in mind. And again, there are some genes like P53, SK11, and P10 that are very highly mutated in somatic genes, so not because you have one, it means those patients have germline, so you have to look at other clinical factors. PD-L1, I'm not gonna go too much in that. Dr. Johnson, I think call it King K. King K is actually approved in first-line metastatic for triple-negative breast cancer, and this is based on Keynote 355 study that randomized first-line metastatic patients to pembrolizumab versus chemotherapy of choice. What it shows was that for patients who had a PD-L1 a CPS score that measures PD-L1 expression in the tumor and in the stroma, those patients had statistically beneficial progression-free survival over the lower expressing PD-L1 tumors, and that was also seen in overall survival. But again, it has to be the more immunogenic tumors, the one with higher CPS scores, that is greater than 10. Keynote 522, which was discussed earlier, again using pembrolizumab in the early setting, was shown to be not only PAF-CR benefit, but event-free survival benefit. What we saw is that independent of your PD-L1 status, there appeared to be a benefit. So then PD-L1 is not necessary for that particular population. I will tell you about the study that I think some patients who cannot tolerate anthracycline, is there an option for them? The NeoPAC study told us, yes, using Taxotere, carboplatin, and pembrolizumab. That was a single line study. Everybody got it. There was a PAF-CR rate for about 58%. So that can be for the right patient an option. We will, for matter of time, we'll go through NTRK fusions. I want to say a little bit about that. This is TRK protein, and I wouldn't go too much into that, is a rare finding on molecular profile. It's only seen in about 0.31% of adult tumors, but importantly, in secretory breast cancers, it occurs in about 90% of secretory breast cancers. Although they are rare, and most secretory breast cancers actually are of the triple negative sort of basal-like subtype. So those patients have potentially this fusion, and there are 2 drugs currently approved that could be options for them. And this was based on this New England Journal article. You see the waterfall plot. This is many different subtypes. Although breast was there was only 1 breast patient on this trial. But what we see is really good response to a highly pretreated population who has this fusion. This is a case report that I published with 2 medical students here, showing one of my patients who had this mutation and in 3 months had a deep PR, currently is in a CR. I think I have 1 other patient. So given how rare it is, I must be the world expert on NTRK at this point. And then TMB MSI and mismatch repair. That drug, again, pembrolizumab, dostarlimab, are also approved for patients with these mutation. I have to say, however, breast, really, there were not many breast patients on these trials, but it's approved if you have those even in breast. And the reason is mainly when you look at it, for mismatch repair, really doesn't really happen in breast as much. High TMB, breast is not one of those tumors, and that's probably the reasons why we didn't see that in the study, but those drugs are also approved for that population. So yes, NTRK, rare, but has drug that's extremely effective, but testing variability is important. So you may think that you send a test and you didn't get it, and it means that that patient didn't have it. So for example, Foundation 1, it's a DNA-only based, but it covers ETV6, NTRK1, NTRK2, but has a limitation with NTRK3. Guardian 360 test really only covers fusion for NTRK1. Foundation liquid, again, has limitation for NTRK fusion in 1, 2, and 3. So not having those, not seeing this on this test doesn't mean that your patient doesn't have it. The 2 testing agencies out there, Caris and Tempus, who do RNA-based testing, those you are more likely to discover any fusions, and that would be a test that would be more dependable to let you know whether or not your patient has them or not. And we will end there, and I thank you very much for your time. All right, so we're gonna move forward